Welcome back. You're watching a video on myasthenia gravis and Lambert-Eaton myasthenic syndrome. So we have talked previously about how the two principal questions in a neurological evaluation are where is it and what is it. The where marks the neuroanatomical location of the disease process or lesion, noting that lesion doesn't merely mean a tumor or a bump, but whatever disruption in the neuroanatomy that gives rise to the patient's symptoms. So we consider, could this be in the central nervous system, in the cortical brain, subcortical brain, brainstem, or the spinal cord? And once we leave the spinal cord, we know that we go to the nerve root and then the nerve. And then at long last, we have arrived to the neuromuscular junction. So we're going to be talking about a couple of disease processes that affect the neuromuscular junction. In this graphic, you can see to the right that there is a nerve bundle and it's sending out extensions to the skeletal muscle, which creates a motor end plate. Here is an electron micrograph of the motor end plates. You can see there's a Schwann cell that comes up and covers these extensions. If you look into the synaptic cleft in the graphic here, you can see that there's a space, and what's going to be released in this space with a neurological impulse through the motor fiber is going to be the release of acetylcholine. Acetylcholine will go and bind to receptors on the postsynaptic membrane, and this will excite muscular contraction. In the presence of some inhibition of acetylcholine, if it becomes blocked and its ligand receptor relationship is diminished, then this will precipitate fatigability and proximal muscle weakness. With this in mind, we're going to talk very briefly about myasthenia gravis and Lambert-Eaton myasthenic syndrome. Myasthenia gravis is an autoimmune disorder of the neuromuscular junction. It produces a painless, fluctuating weakness of muscle groups, which frequently affect ocular signs and symptoms, things like ptosis, which is shown in the photograph to your right, and then diplopia. So anytime someone complains of double vision, it will be in our differential diagnosis. It is fairly prevalent, with 14 to 20 per 100,000 and anywhere from the 30,000 to 60,000 depending on the prevalence at a particular year. But this is common enough that you very well could see this in your clinical practice. So the pathophysiology of myasthenia gravis is interesting. It is a T-cell dependent immunologic attack on the muscle acetylcholine receptors. So the T-cell mediated activity produces antibodies which inhibit the ligand receptor site relationship of acetylcholine and the receptor. Also potentially implicated is the muscle-specific tyrosine kinase. Why do these antibodies get produced? Well, it is not well understood, but what is known is that 65% of patients with myasthenia gravis demonstrate thymic hyperplasia, and 10% of them exhibit thymomas, which can be malignant. So the presence of these thymic changes suggests that there's some role in the thymus programming for the antibodies that get produced. So in terms of evaluation, what we're going to see in physical exam, weakness of the muscles with repetitive movements. We will not see any atrophy, fasciculations, or sensory loss because this is a pure motor end plate lesion. And then the muscle tone and reflexes will typically be normal. Now, if we refer the patient to a neurologist, they may perform some nerve conduction studies. And on the right, this is a nerve conduction study of a patient with myasthenia gravis. What you can see is initially a nice organized single amplitude electrical impulse. Then you see the electrical impulse becomes disorganized with repetition, and then a complete loss of amplitude, which correlates with the patient's weakness. Now, the neurologist may also order acetylcholine receptor antibodies. I'm not familiar with that, but one thing that we should consider doing is CTing the chest to make sure that they don't have a thymoma. And then lastly and importantly is the edrophonium test, sometimes called a tensilon test. So it's a reversible acetylcholinesterase inhibitor, and when administered intravenously to patients with myasthenia symptoms, we should see a complete resolution or near complete resolution of those symptoms. Let's look at a video here of a patient that is receiving the edrophonium test, and you can see that her baseline is on the right. She has a significant ptosis, which obscures the greater portion of her iris and pupil, and then we'll see how it responds to edrophonium. So you can see if you compare her with her baseline on the right, she's kind of squinting a little bit bilaterally because it precipitates a little irritating sensation on the eyes. But you can see that that is a complete resolution of the ptosis that was precipitated by myasthenia gravis. So management for this is going to again be done under the aegis of a neurologist, but acetylcholinesterase inhibitors are thought to be first-line treatments. And then if patients exhibit flares or crises, they may receive corticosteroids, immune modifiers, and then usually hospitalized because they can develop respiratory distress, as with Guillain-Barré, and then they can receive IV immune globulin and plasmapheresis to assist them with their immune recovery. So medications reported to aggravate or induce myasthenia gravis. The point is not to memorize all of these, but the point is to know that if you have a patient with myasthenia gravis in your practice or that you encounter in the emergency department, it will be key to make sure that any medication that you plan to give the patient, that you look that up and make sure that it's not contraindicated in myasthenia gravis. So lastly, we have Lambert-Eaton myasthenic syndrome. We'll very briefly touch on this because it is thankfully quite rare. Now, it too is an autoimmune disease that affects the neuromuscular junction. The mechanism is different in that it produces antibodies to the calcium voltage-gated channel. This is thought to be idiopathic, but in 1 to 3% of people with small cell lung cancer, they develop this. So the small cell lung cancer may be generating aberrant antibodies that attack the calcium voltage-gated channels. Now, these folks will have autonomic symptoms, and with initial increased movements, they can actually show some initial improvement. The treatment for this is an agent with which I am not familiar, 3,4-DAP, and again, it is thankfully rare. I point it out because it does sometimes show up in board questions, so be aware of it. Its association with small cell lung cancer, in that it does not have eye muscle involvement, it does have autonomic symptoms, and that with repetitive nerve stimulation, you will see initial enhancement. Here are the sources that were used in the production of these neurology videos. This marks the end of the video on myasthenia gravis and Lambert-Eaton myasthenic syndrome.